Dear Chair, dear audience, let me introduce my PhD topic, which is the link between cognitive training and neuroplasticity in mild cognitive impairment. I'm Eszter Radics. I'm a cognitive neuroscientist and a second-year PhD student. My supervisor is András Horváth, and my SMS is Mari. And my vision is that all preventable dementia cases are prevented, and my mission is to evaluate cognitive trainings to delay or prevent dementia. So I have two ongoing projects. The first one is investigating the effectiveness of cognitive training in adults. This is a systematic review and a meta-analysis. And the second one is advancing initiatives of dementia risk reduction, which is a survey. So about the first project. As you may know, dementia is on the rise and it will affect 139 million people by 2050. And there is no cure yet, but different lifestyle interventions show really promising results. A recent study found that at least 40% of all dementia cases are linked to modifiable lifestyle and environmental factors. A wide range of cognitive trainings exist, but their exact effect on objective neural parameters are still unknown. So our clinical question is, how does cognitive training influence structural and functional network connectivity in the brain? Our population is adults. The interventions are designed and validated cognitive trainings. The comparisons are not designed and validated cognitive trainings. And the outcomes are objective markers of cognitive risk, such as MRI and DTI. Our hypothesis is that cognitive trainings have a beneficial effect on the brain compared to no intervention. And the clinical and research implications are to delay and prevent dementia and designing better trainings. We conducted a systematic search on the 30th of November 2023. And here you can see the search key. We ended up with a bit more than 6,000 records and ended up with 9 eligible full texts. So our first outcome was fractional anisotropy, which is a diffusion tensor imaging derived measure. It is a scale between 0 and 1, and where 0 means that the diffusion is equal in all directions, and this means reduced structural integrity, while 1 means unidirectional diffusion, which means aligned fibers and white matter integrity. This measure is sensitive to white matter degeneration in the early stages of Alzheimer's disease and MCI. So here you can see the results of this outcome. We analyzed 115 patients, and the heterogeneity is 87%, which is very high. And well, the mean difference reached 0.01, which is not statistically nor clinically significant. And our next outcome was hippocampal volume, which is associated with late life cognitive decline. Smaller hippocampal volumes is associated with poorer cognitive functions such as working memory, processing speed, and verbal learning. These cognitive domains are particularly vulnerable to decline in non-pathological aging. And here you can see the analysis for this measure. We included 349 patients, and while the heterogeneity is 0%, from the confidence intervals you can see that it's very high, probably, again. And standardized mean difference reached 0.01, again, which is not statistically nor clinically significant. Here you can see the project progress. I have to add that the manuscript needs some minor changes still, so it's not fully done. And here you can see the baseline characteristics of these the included studies. Our paper has strengths and limitations. About the strengths, it is the first meta-analysis in this topic assessing objective outcomes, and we followed our protocol, the guidelines of the PRISMA, and the Cochrane collaboration. And our limitations include baseline differences, issues of randomization and stratification, very small sample sizes, and really high heterogeneity between the papers. So to conclude, the benefits of cognitive training seen in neuropsychological outcomes are not that evident on objective markers, and to prove their efficacy, more and better designed research are needed. Implication for practice would be to assess their efficacy first before advising them as a preventive method. And our implications for research are ensuring better randomizations, no baseline differences, stratification for cognitive reserve, and usage of multiple follow-up times. So the current status of the paper is that we are working on the last parts of the manuscript, and we are planning to submit it to Alzheimer's and dementia in February. And my second topic is advancing initiatives of dementia risk reduction, which, as I mentioned, is a survey. So pathological changes of dementia start about 20 or 30 years before the onset of the disease, and early biomarker testing could enhance the benefits of preventive methods, although it is challenging to communicate these results to patients. We believe that personalized patient and clinical communication could lead to more efficient health and disease-related behavior, as well as better quality of life. And investigating the differences between European and Hungarian protocols could be beneficial in improving the health. Our clinical and research implications are understanding clinicians' perspectives on biomarker testing and improving national dementia care. So we are implementing the latest survey in the Hungarian population, as you can see on the picture. And we are updating this survey according to the 2024 guideline of Alzheimer's diagnosis. And we are also extending the survey for general practitioners. So in summary, I have these two ongoing projects, and you can see the planned submission dates here. And I would like to thank your attention with this quote from Aldous Huxley: "Systematic reasoning is something we could not as a species or as individuals possibly do without, but neither, if we are to remain sane, can we possibly do without direct perception. The more unsystematic, the better, of the inner and outer worlds into which we have been born." Thank you.
Congratulations. How many persons are estimated in the second project for the survey?
For the survey, well, we have a whole list. Thank you for your question. We have a whole list of people to send this. But the exact number, actually, I'm not sure. I think it should be around 50 clinicians and like 20, maybe 20-ish patients or caregivers. And for general practitioners, we are not there yet, so I'm not sure. Thank you.
Yes, I have also a question. I appreciate that fractional anisotropy had no significant result.
Yes.
But if you see the papers, the heterogeneity is quite high. But it is because that the standard deviation of each result were very narrow. And on the contrary, if you check the hippocampal volume, the standard deviation was extremely high. What could be the reason for that?
Yes, so it is because in the hippocampal volumes we had to count do maths for the confidence intervals. So yes, for this reason, I mean, it was not given, so it is not a proper number. And we contacted the authors for this, but we didn't really get answers, so it's not going to change, most probably.
Mm-hmm. Okay, so you just hypothesized then?
I'm sorry?
So it's not a true confidence interval, just hypothesized then?
Well, the statisticians did all this work, so
yeah,
I'm not
okay.
100% sure.
Great. And for your conclusion, you mentioned that objective markers are not working really good in this topic.
Yes.
And would it mean that we need better markers, or the cognition therapy is not the best for this situation?
Well, we believe it is good for the quality of life, and in cognitive functions it can be beneficial, but maybe it should not be advised as preventive method or symptom delaying method, because we do not see in the biology these very nice results that we see on neuropsychology.
Completely agree. Okay, thank you very much.